Good morning, good afternoon, good evening, wherever you may be across the globe. Welcome to the third webinar of this Culture and Health webinar series for 2020. My name is Niels Fietje, and I work at the WHO Regional Office for Europe, where I'm part of the Insights Unit and where I lead a project on the cultural context of health and well-being. The webinar you're about to listen to and hopefully participate in is part of a series which is funded by the Wellcome Trust, and it's the product of a collaboration between WHO Europe, WHO Collaborating Centers, and on Global Health History at the University of York, as well as the WHO Collaborating Center on Culture and Health at the University of Exeter. So the webinar series examines important and timely topics at the intersection of health, well-being, and culture, and it intends to create a forum that brings together experts from the humanities and social sciences, senior officials from WHO and the UN agencies, voices from NGOs, think tanks, civil society, and of course the wider public to exchange ideas and perspectives, exploring the social, historical, cultural contexts of health. So during this webinar, our panelists will spend approximately 30 minutes making brief opening statements about today's topic and the role of culture in defining and advancing digital health. The remaining 30 minutes will be dedicated to discussion, including questions from you online via our website, via a website called Slido. So I'd encourage you to go to www.slido.com and enter the event code #WHOCH. And on that website, you'll be able to ask your questions, and also you'll be able to vote questions up or down, depending on how relevant or how interesting you find them. So please also be aware that we have a questionnaire up on the Slido page, which helps us to evaluate and improve the webinars. Please do take a moment to fill this in at the end of the webinar, and if you'd like to be kept informed about the webinars, please leave your email address there so we can get in touch. So with all that being said, I just wanted to say a few words by way of introduction to today's webinar, which looks at e-health or digital health, and how the developments over the last few years in this area are really bringing about major changes, including in the ways in which health information is disseminated, how patients interact with health systems, how records about individual patients are being kept, and even how healthcare itself is being administered. Now, the promises of e-health are enormous. More control for the patients, time savings for the healthcare providers, cost savings for the health systems, and so on and so forth. But this seminar specifically wants to ask, what are the potential unintended consequences when a generational shift like this occurs? Particularly in relation to health equity, which is a huge topic within the WHO European region. The question really is, do digital solutions help promote health equity, or are they creating new inequities? And so now, to some extent, I accept that this is a rhetorical question, and I don't think I'm going to spoil the ending by telling you that they do both. But in today's seminar, we really want to tease out how equity and inequity are being affected by digital health and how we can be sensitized to these issues and what we can do about them. So with all that being said, I'll take a back seat. It's really about our contributors here today, and let's get going. I'm briefly going to introduce each speaker one at a time when they talk. So to kick us off, it's my pleasure to introduce Emma Rich. Emma is a professor in the Department of Health at the University of Bath, and one of her specific research interests is a focus on the socio-cultural dimensions of digital health technologies, and as part of which she's just completed a project on young people and digital health, which you can find more info about at www.digitalhealthgeneration.net. So with that being said, Emma, it's over to you. Please take it away.
Thank you, Niels. And just firstly, thank you so much for the invitation to join you today and the panel. I'm really excited to be here, not least because I think this is a really significant moment, as you've alluded to in your opening comments, particularly with COVID-19, which I think has presented many challenges, as we know, but which has sort of dramatically accelerated the extent to which digital healthcare systems have been implemented around the world. And I think, as with any technology innovation, there's both optimism and skepticism around that. But irrespective of that view, I think it's really important that we have events like this to explore the impact of digital health on different populations, particularly those that we see as most vulnerable within our healthcare systems.
Emma, if I can interrupt real quick, I think you may have accidentally turned off your camera.
It's saying unable to start, so there's obviously
Okay.
a problem there. Okay. Hopefully that will kick back in.
Great.
It says, I don't know if this is helpful, Niels, but it says you can't start your video because the host has stopped it.
Oh. Okay. Well, I'll look into that. Thanks a lot.
Okay. I'll carry on talking whilst you look into that. Okay. So we know, I think, from the literature that health inequalities and social determinants have taken an important place in policy discussions, and likewise, digital health has been the focus of much research and policy discussion. But there's a paucity of research which brings those two things together, and a lot of that is quite context specific or quite short term. So, as you've mentioned, partly in addressing this gap, I recently led a Wellcome Trust funded project looking at the experiences of over 1,000 young people in the UK and how they variously engage with, interpret and make sense of digital data in relation to their health. And I'm certainly happy to sort of talk through some of the findings today, but overwhelmingly we found a number of inequalities and a number of differences in the way that young people engage with those technologies. And that really speaks back to the need for a more nuanced understanding of what we mean by equality. And I think, you know, the notion of a digital divide is in some ways quite problematic. What we're seeing is a diverse range of literacies, abilities to interpret, and experiences around digital health, which impacts on how that translates into health opportunities or health practices. As part of that project, we also looked at the policy frameworks in the UK that were kind of defining and shaping how we think about digital health. And we can perhaps unpack this in the discussion today, but we found three sort of key ways in which digital equity was being framed. So one was around this kind of neoliberal notion of digital efficiency and empowerment. So very much a focus on personalized health and individual responsibility. And I think there are a number of sort of problematic issues that come with that and the burdens that go with that on individuals. And it'd be interesting to hear in terms of what patients have to say about that from Anna's perspective today. The other issue was this idea that in terms of equity, that we're democratizing healthcare in some way through greater joined up data sharing and collaboration across numerous agencies, which is, I think, presenting both opportunities and problems and challenges. And then finally, this notion of kind of citizen autonomy, that with the rise of things like the NHS app, online health records, etc., that this is leading to greater autonomy with patients. And what we found is that actually what goes with that is a great deal of burdens and anxieties, and a shift as well towards sort of marketplace individualism. So this turn to the market to purchase the right apps, the right technologies, and often those burdens reside with what we might call the worried well. And certainly in our Wellcome Trust project, what we found is that in some cases, young people have to have technologies or apps removed from their phones because they were becoming excessively anxious and obsessed over their health practices. So at the one end, we might have inequalities around particular groups who can't access healthcare. And at the other end, we have the extreme of the very worried well, who are heavily invested in purchasing, consuming, and monitoring their health. And this can lead to inequalities in another way, which is more about anxieties, disaffection, and kind of excessive monitoring at the individual level. So just a kind of few points that I think we might unpack in the discussion, comments, or I guess critical questions from me that's come out of that work. I think the first is to sort of situate these policies within the broader context of healthcare systems. And we know that in a lot of countries where health inequalities has been a sort of stated policy priority, that hasn't necessarily translated into the removal of disparities or health inequalities. And partly, I think, and that's certainly evident in the literature, is because of that focus on what we call a lifestyle drift. So we start in policies by recognizing the need for upstream action to address wider social economic determinants of health. But there's a drift downwards to ultimately digital solutions being placed as an individual responsibility to managing conditions and keeping healthy. And interestingly, I think we've seen increased anxieties around that during COVID, whether we are using the right technologies or downloading the right apps to keep our children healthy or keep active during lockdown. So I think, again, that presents some interesting challenges. And I think perhaps really importantly today is to think about what we really mean by equality. And for me, that means going way beyond this idea of having good internet access or whether we have the right information. It's also about relationalities of power. So we know, for example, that mHealth interventions, for example, to increase women's access to health resources are deeply affected by the relationships they have, by the gender dynamics, by culture and ethnicity. That means that doesn't necessarily translate so easily into access and opportunity. And likewise, I think for me, Sonia Livingston and Ellen Helsper, their work around this idea of a digital, a continuum of digital inclusion is really helpful for our discussion today. So let's not think of a kind of digital divide of the people who have or don't have access to digital healthcare, but there is a very complex set of issues around interpretation of data, digital literacy, and culture and relations of power that really affect both digital practices and the opportunity to translate that into practice. And just again, by way of example, what came out of our research was a really striking issue of inequality, that for young people, having a trusted adult, whether that was a teacher, a parent, or a friend, who could help them navigate this complex sea of data platforms and translate information and data, was an issue of equity. Some had it and some didn't. And I think for me, that's really raised some questions about what kind of skills young people are growing up with, and how we better equip people through digital resources, skills, and education. And just finally, I think for me, one of the things to really think about here in terms of policy development is how we actively involve different user groups, both in the design of technologies, but also in the implementation and design of policy around health, and really make that an upstream engagement and potentially even citizen-led. So some really innovative things happening around that in terms of community platforms, living labs that might bring different user groups together and really think about how we think about equity in those cultural contexts. So I'll finish there, Niels, and hopefully some questions to perhaps springboard from in the discussion.
Thank you very much, Emma. That's very interesting and lots to build on. I mean, I do have a few questions around this kind of digital continuum that you mentioned, and also the kind of methodologies about being more nuanced. It's one thing to say we need to be more nuanced, we need to not think so black and white, but how do we actually go about that? I'm going to park those questions for now, so that we can have we can give our next speaker a chance. Anna is going to give us a quick presentation. So Anna, if you wouldn't mind, while I introduce you, to try and start to see if you can share your presentation. Mm-hmm. And I'll say a few words about Anna. Anna Stavdal is a family medicine specialist who's been working for the past 30 years, I believe, in Oslo's inner city. But in addition to that, she's also held leading positions in family medicine organizations for 25 years at the national Norwegian level, at the Nordic and European levels, and now also at the global level as the president-elect for the World Organization of Family Doctors. And most recently also, she's been selected for the WHO Pan-European Commission on Health and Sustainable Development, which is entitled Rethinking Policy Priorities in the Light of Pandemics, for which I just wanted to say congratulations to that as well, Anna. So over to you, really. Are you okay with sharing your screen? Does that work?
Yes, now I have my presentation on my screen. So if I wait for the
so you will have to, down below, there's where you have all your options with mute, stop video, etc. There's one that says share screen. If you click on that, and then you have a number of windows that open up, and you should select the one that is your PowerPoint slide.
Do you see my screen now?
You might have to click OK.
Okay.
Or share, rather.
Yes, share screen, right? And now, yeah, there we go.
There we go.
Now.
So now we can actually see your screen, but not, yeah, and there's the, there we go.
And a very short moment.
Excellent.
There.
There we are, fantastic. Over to you.
Thank you. First of all, thank you for inviting me. Good to be back. Very nice to listen to Emma, whom I haven't met yet. You really gave us a good background, mentioning a lot of the factors that impact outcome of health services, being digital or not, but even more important now to discuss in the digital era. I will share with you, or first of all, needless to say, but the goal for WONCA, my organization, the World Organization of Family Doctors, is health for all, universal health coverage through strong primary care. So the multidisciplinary primary care teams with highly qualified family doctors is key to reach that goal. And that is my point of departure. The photos on the slide are taken in my practice over the last couple of years, snapshots that give you an idea of the diversity in my practice, as you see it in general practice or family medicine all over Europe. From cradle to grave, all ages, both, or should we say all gender, people who have lived all their life in Norway, and others who have migrated from other parts of the world. And together, they represent the whole spectrum of medical issues. And by the way, all of them have accepted to use their pictures here. I showed the pictures to remind us that medical service is about, or medical service delivery is about people. And disease affects each person individually, physically and emotionally. So we could say we are the result of millions of years of genes and biology, decades of psychological experience, the culture we grew up in, and the times we live in. And all of this comes to the forefront when we get sick. So in diagnosing and treating, also in prevention, we need to be aware of that and take all the aspects into consideration. The biological, psychological, and social elements. And digital tools, of course, don't change that fact. This is necessary. The question is, how can digital tools help us in our effort to do exactly that? I could now touch upon a lot of things and different details, different tools, but I will stick to the family medicine setting and also diagnosing, treating, and preventing disease in family medicine. So I'll share with you some issues which interest me in this regard. The first one alludes directly to just what I just said. we know that the power of primary care in general and family medicine in particular is embedded in the core values of the trade. We provide comprehensive, continuous, and personal care. We know that that gives better health outcomes, better population health. So, how are these values challenged by digital tools or digitalization of healthcare? A huge question. Emma, you mentioned already some of the variables. I'm not speaking black-white, but the continuum of age, education, access, physical access, electricity, recharging devices, but also accessibility in terms of applying a critical assessment of what you actually are offered. What knowledge are you offered through these digital tools? And who are making these tools, on what basis and with what interests? Money is time. So time is money, I mean. One question is, to me, will we or are we at risk of ending up where people who are, let's say, poor or on the poor side of the spectrum, are they left with digital health? Whereas rich people who know they can pay and they can find what they get, will they be the ones who are able to pay for my time in the future? So I can provide them with personal, continuous, and comprehensive care the way they want it. This is, of course, critical to when we are speaking inequity in access. So second question, again, already mentioned by Emma. How do we avoid that digital tools increase overdiagnosis and overtreatment? We could say that is, in these days of epidemics, we could say this is really the silent epidemic in healthcare worldwide in our times. We could think that artificial intelligence and precision medicine could help us to reduce overdiagnosis. But again, it then depends entirely on how the algorithms these tools are based on, what knowledge they are based on. And numbers is very, my patients are so easily, and I guess you guys also, are so easily seduced by numbers. So that the moment you could pinpoint things in numbers, you have the truth, sort of. And that does not comply completely to what I said about how disease and medical conditions present themselves in the individual. Okay, so that's the second point. The third point, how do we ensure a multi-level approach with a vision and also an action roadmap for creating, implementing, and evaluating digital tools, all from the records to the apps, focusing on specific conditions or risk factors. And what I must stress here is I see a lot of beautifully developed tools and electronic patient records, etc. But where we often miss out is the feedback from the users, being patients and physicians and other health professionals, to say, how does this really work out in practice? Because before we get that far, the snowball is already rolling and getting bigger. And the financial mechanisms keep it going, whether it is good or bad in practical use. I can also here just mention an unpublished survey conducted now during the pandemic among Norwegian GPs, asking, is digital tools and online consultations, that was one of the questions, useful? Can we use it? Can it replace or compete with a physical consultation? And there's a rough estimate that they said more or less 30% maybe of what we do can be handled online. But mind you, if you know the patient beforehand, before you started here, the digital part of your relationship. This is not analyzed data, it's only an input to the discussion. I think many physicians, not only in Norway, would say the same thing. And we could start discriminating between physical complaints and symptoms, psychiatric conditions. But all the same, the main question is, how does the physical presence, the physical meeting affect the outcome of what's happening in the consultation? And we don't know everything about that. We can guess, we have some ideas, but that is really, question which should be basis for research as well. Fourth point, how do we avoid burnout among health professionals? Digital health means for patients and health professionals increased accessibility. And during the pandemic, I'm sure you also have heard reports from the field. And certainly I can say from my own experience that seeing patients online is such another thing than meeting them physically. You are, in theory, accessible 24/7. And in the start of the pandemic, that was actually the case, and that was meaningful. But now, where we in this country at least think we are in sort of control of the pandemic, it's hard to get the horses back into the barn, because now people are used to this, that they can access the doctor almost all the time, and not only with acute issues or issues relating to the pandemic. So here I'm back with my patients and have a look at them. And also here I am now added in my digital consultation room in March. I think that's for now.
Okay.
Yeah, and I'm looking forward to the discussion.
Thank you very much, Anna, and apologies that I interrupted there. That's super useful and very, very interesting. I think it's very interesting to hear the kind of doctor and patient perspective there. I just spotted a question on Slido that I'm going to be very interested to find out more about, which is to do about health inequities amongst physicians and doctors. So in terms of their ability to provide online care and the inequities that might potentially arise there. So I'll get back to that as well. But before I do, I'm going to hand over to Clayton to kind of give his perspective as a WHO, a dear WHO colleague, but also as somebody who's recently become the lead on the WHO flagship initiative on empowerment through digital health, which is part of the European program of work. Clayton, for many years, has been providing support and guidance to e-health development and capacity building initiatives across the region's 53 member states. So, Clayton, I'm really looking forward to your kind of policy perspective on this topic. Over to you.
Thanks very much, Niels. Good afternoon, colleagues, and thank you very much, Emma and Anna, for such wonderful interventions. I think you've really projected very different but very interesting thoughts and injected them into this discussion. So what I really wanted to do with this intervention was firstly to really bring up, and I think it's quite unique, that we actually are discussing culture and inequalities and digital all in the one session. It's not something that we usually do, and I think there's a lack of awareness in particularly the digital health community to some of what we would call cultural aspects that are intangible yet playing quite a strong part in success or failure in digital health adoption. So actually, I wanted to start by actually talking just a little bit, very briefly, about the idea of culture and what culture is, because I think somehow, Niels, as somebody who works very much on a daily basis in terms of culture, you might have a very fixed perception of what culture is. But I think that in the digital health community, we may have a slightly different interpretation. So for example, we often talk about a culture as a way of doing things rather than a specific ethnographic or social contributor. For example, we talk about a data science culture, or we might even talk about a culture of success. Now, in my job working for the regional office, I have the privilege of actually advising countries and ministries of health on actions in order to strengthen digital health and digital health infrastructures in their countries. And sometimes I find it quite interesting to look at countries which may be literally adjacent to each other, but have very different levels of digital health maturity. And I've often looked at this and reflected on it and asked myself, what are the contributing cultural factors or differences that may have accelerated in one country and perhaps not accelerated so much in another? So we talk very much in this perspective in terms of very broad cultural factors, or even drivers, as we would call them, that have led to transformation at a national level. And what I'm interested in really exploring is, can we actually identify some of the intangible factors that lead to a quote unquote culture development that go beyond obvious elements such as trust? We talk a lot about trust of digital technologies, trust in that context. But when we strip away all of the other enabling factors, there still seems to be a cultural and intangible cultural factor that is important to success and also important in addressing inequalities. So firstly, what I wanted to do was actually to talk about the digital health inequities or inequalities themselves. So what do we mean by this? So firstly, at its most basic, we're talking really about barriers on access to health information and to care delivered digitally. So again, Anna, I tend to be a little bit in love with the numbers, but when we look at some of them, half of the world still doesn't have access to the internet. 45% of people only are connected in developing countries, and in the least developed countries in the world, this number drops down to a proportion of around about 20%. We know, for example, in the United Kingdom, just taking one of our member states, 1 in 5 people lack basic digital skills or don't use digital technology at all in any way. So when we look at inequities or their corollary inclusion, we look at in terms of defining digital skills, connectivity, and accessibility. And that's really how we look at how we can address inequities. But I think there's also another emerging perspective which is important to consider, and that is inequities in terms of access to timely access to high quality health data. Now, as many of us know, data-driven tools in healthcare and public health are really starting to actually show their value. And as Anna mentioned, also in personalized health contexts as well. So there is, I think, a cultural dimension which plays a part in the relationship between data and equity. And addressing this and the willingness of an individual or of a health system to share data is also an important question we need to raise. So who is impacted? Who is impacted by the inequities? Well, we know that vulnerable population groups are disproportionately impacted by the digital divide. It's likely that digital technologies will increase health inequities associated with increased age, lower levels of education, and lower socioeconomic status, including poor housing. But I would also say that there appear to be a number of other groups who are particularly vulnerable to digital health inequities. This includes immigrants and refugees, disabled individuals, rural populations, and also those which have language barriers to their local predominant language. Not surprisingly, all of the groups that I've just mentioned are also typically the heaviest users of health services in the system. So how are individuals being excluded? And I think there's three major ways which we see this kind of exclusion coming around. And this is where I think we need to explore more about where the cultural factors actually play a part in this exclusion. So firstly, there's a very obvious prevention, a kind of a hard barrier from access to services that may be provided digitally. So a so-called shutout, and that can also come in the form of, for example, not having a compatible device or a mobile phone that might be required to access a specific service. Then there's the inability to navigate through digital solutions which might be provided. So either a lack of awareness that they exist, insufficient digital literacy and competency to use them, or again, language barriers that may play a part. And then finally, as Anna mentioned, exclusion through cost barriers. So we are certainly entering an age where a certain number of services directly to an individual are on a cost basis. And if individuals are unable to afford them, then obviously there's a barrier which emerges there. So what type of benefits are individuals being excluded from? Well, certainly access to vital care services. And those are the services which again are becoming mainstreamed by health systems, and more are expected to be able to use them. There's also the sense of being excluded from the ability to self-care or self-manage, in particular, long-term conditions. And then also, I think there's a factor of reduced loneliness and isolation. That's something that plays a part here. If you are excluded from digital services, then really that does also play a part. Looking at it also from the system perspective, obviously, the exclusion brings about a higher cost in delivering services because we're essentially dealing with the individuals in two ways. So from a very kind of system perspective, then that's considered to be something that would increase costs. And also a more appropriate use of services, including primary care and urgent care. So again, those inequities and inequalities actually lead to barriers in those perspectives. We know that people who are digitally excluded are at risk of reduced access to health services and poorer health outcomes. They are not able to leverage the benefits of digital health and the access to the information to enable them. We also know it impacts the overall business case for the health system. It slows or reduces the ability to perform health services and becomes costly to maintain separate entry points. So very briefly at the end, what can we do about it? So to tackle this effectively, we need health authorities and even a broader portfolio of government to provide stewardship for a number of different actions, which include understanding and treating the technical and visible elements of where we have these inequalities emerging. So for example, we need to understand that tackling broader welfare, education, and socioeconomic factors are more important, and in fact, I would argue the most important in understanding why an individual community may actually be marginalized from accessing services through digital means. We need to expand broadband and other digital infrastructure. So I think sometimes we make an assumption that people can access digital services, but that is in fact not the case in many parts of Europe. Delivering programs of digital literacy of the population, again, I think is a huge thing that we don't actually look at. And there's a big cultural perspective involved in those as well that will actually really increase the uptake of digital solutions. And then finally, including or enhancing digital health and medical education and including continual professional education, I think is another action that health authorities can actually do to ensure that inequities are addressed and that also that we're giving an opportunity for cultural perspectives to be included. All right, so I'll leave it there at this perspective. I think that, again, the discussion is very rich, and as Emma pointed out in the beginning, there's also very little, I think, on this particular combination of topics. But again, it still remains a very, very important factor in the uptake and success of digital health in Europe. Thank you.
Thank you very much, Clayton. That was very, very insightful, very, very interesting to hear. As I said before, I'm going to go to the kind of Slido questions in a moment. And in fact, I'm already going to start integrating them a little bit, but I wanted to come back to that question around kind of defining vulnerable groups. Every single one of you has talked about vulnerable groups in this space. And Emma, you kind of, and one of our questions on Slido is also about speaking more about hard to reach groups on digital platforms. Who's at risk of being left behind and how do we address it? So I think each of you have said a little bit about that, but I'd be really interested to know a little bit more about this concept that you talked about, Emma, the digital divide or the digital continuum, and this idea about breaking down these stereotypes, I guess, that we have about these people have access, these people don't have access, these people are vulnerable, these people are not vulnerable in the digital, because I think the digital space really jumbles that up quite a bit. Like, you know, I would have naively perhaps assumed that young people have very little problems with the digital health technology, but here you are, Emma, having just done a project on exactly that and nuancing that quite a bit. So Emma, if I can go to you first, can you talk a little bit more about this this challenge of exploding these kind of black and white views of vulnerable populations, and then also maybe say a little bit about some of the methodologies for understanding your groups a little bit better, like understanding a bit better who is vulnerable and who is not vulnerable within a kind of large group.
Yeah, thank you, Niels. And I think Anna and Clayton have both really spoken to that very well in terms of, you know, broader understandings of both patient needs, patients' experiences, but also, I think, how we think about equality or equity within the digital health context and expanding that. So I think for me, through the project, what really came out of that was there is this assumption, for example, that young people are digital natives. And I think if we start with that point, this idea that, you know, being digitally savvy is just a case of being able to access services, know how to use them, and navigate your way through the technical world, if you like. And I think where this issue of absolutely some people have access and some people don't, but what young people told us was that it's incredibly difficult to even find your entry into digital health services. And what they do is they begin by a kind of needs-based search for information. So there's very little loyalty towards a particular platform or a particular app. It's very much as and when health issues arise. And I'd be really interested to hear Anna's perspective of this around patients expressing needs for technologies at certain moments in their sort of health experiences. And actually, even the issue of how do I choose what to use is overwhelming. So this idea that they are native and kind of born into the skills and resources to navigate that is just not true of their experiences. And when you start to unpack that, that was very different in terms of issues of social class. So the idea, for example, that family practices around technologies greatly shape what young people do. So just by way of example, some young people talked about having, you know, family competitions where Strava was used to report their cycling or how much physical activity they'd done during the week. But importantly, it's about making sense of what they're accessing online. So if you take something as simple as a Fitbit, you ask people what 10,000 steps mean, and actually it's very difficult to answer. And when you then look at that in terms of vulnerable groups, perhaps it's your first time exercising, perhaps you have a disability, perhaps you're over the age of 65. Is 10,000 steps meaningful? And that's quite a simple example, but what we're seeing is a lot of people quantifying their health, be that sleep patterns, exercise, and there's often a tension, and I think this is where equality becomes very difficult to unpack. There's often a tension between embodied experiences, pain, pleasure, fatigue, and what data might tell us. And again, just by way of example, one of the participants in our research had told us that she'd had a really bad night's sleep, and yet her Fitbit was reporting that she'd had a very good night's sleep. And actually, if it wasn't for her, you know, having a very supportive mother who could sit down and she could talk about, well, what does this data mean? It's very difficult to kind of translate that into your health practices. But just what things might we look at in terms of inclusion? So helping young people or helping different groups find their entry point into those health services. And I think Clayton's spoken really well about this. How do we make those accessible? And it's not just an issue of broadband or accessibility, but also how we promote and help people navigate through the wealth of information and choice that they have. Ensuring that they have skills and resources, and there's examples in the UK of the Tinder Foundation working with groups to help skill up and resource people to be critically discerning of those digital platforms. Processes around interpretation and translation of data, and again, cultural difference where, for example, in certain cultures where having a mobile phone becomes the ownership of a male rather than a female in certain cultural contexts. And some really interesting work around women who were looking for information around HIV, some of that becoming very problematic in the context of gender dynamics and the type of information that was being found. The ability to translate, so this ownership and burden that we place on people that we have to find more and more information, but what opportunities, and I think again Anna spoke to this really nicely, what opportunities do people have to translate that information into opportunity without making them the responsible for their own positions of inequity. And I think the other thing I wanted to raise was issue of safety and security and ownership of data. And again, Clayton spoke to this, but interoperability, the transference of data, and what risks come with that. How are algorithms designed to take in account of these cultural differences and variances? And also, will we reach a point where data becomes the defining variable as to who has access to healthcare? And I think, Anna, again, I think you spoke about the sort of rich and poor, but also for me, there's a sense of, I think we've seen this happen in think tanks. Are we getting to a point where people have to demonstrate through their data that they've had healthy lifestyles in order to access healthcare systems? So I also think we need to consider how data can be used in ways that create new risks and new inequalities and define populations in quite stereotypical ways.
Thanks, Emma, for those thoughtful pointers. Anna, if you don't mind, I want to pick up on something that Emma mentioned, and which I think you're uniquely positioned to give us an insight on. How often in your practice do you find people? I mean, how much of an e-health expert have you had to become almost by default as a family doctor, helping people navigate, digital tools, having to advise them on these issues? And do you get the kind of feedback that Emma was asking you about patients saying, oh, I could really do with this app or that app, or the improvements to this type of technology or that type of technology? How much of a digital health expert have you kind of become by necessity, as it were?
I don't know if I can, how much of an expert am I in digital health? I'll choose to answer you this way, because basically what Emma said about interpretation and making sense of the information we get, that is basically the task the family doctor is mandated with, digital health or not, right? What we see is that we are overwhelmed with information, we as a population and our patients are, and eventually, of course, this comes into the family doctor's office. I think I'm improving. I never had any training, so I picked up here and there. But what I think the most important thing the most important way I can help people is when they come with their apps or the numbers, Clayton, of this or that, or a risk factor or whatever. If I can manage to wind back and have a conversation on what was the problem, was there a problem, and what was the problem, and then we can see if the data you are now bringing to me here in this consultation, if it can help us to solve that problem. Is it relevant to what you actually asked for? What I very often see is that the agenda is shifting the moment the digital tool comes into the process. And my job, as I see my job, and that is not to disqualify all digital tools. I could say a lot of nice things about digital tools, but to take a step back and to say, what's the agenda here? What are we actually at? And I think this brings me also to something we haven't discussed, but Clayton, you mentioned education and training. And we are now in a situation where we, as grown-ups, are training younger people. That's the way it always has been, and I hopefully will be, because experience has a value as well. But we are actually now training our younger colleagues in an environment we don't know. There are certain things we don't have much experience from. That is actually a problem. So we have to find balance between sticking to the old, the values, and then see if we together can implement those in this digital environment. So it's not an either or thing. I don't know if this answered your question.
Yeah, no, that's. I mean, and it's obviously a huge topic to expand on. I actually want to take us in a slightly different direction next, and give you the chance, Clayton, to kind of. I mean, I think there's a natural tendency on the panel to kind of nuance and question and challenge some of the strident progress that EALT is making, and to kind of perhaps say, slow down, look what's happening here. But on the other hand, I want to give you the chance, Clayton, to also say a little bit about some of the successes. And there's a question on here, by clearly someone who's a convert on Slido, who says the value of digital solutions has become crystal clear during the ongoing COVID-19 pandemic. Have you seen any exciting and new developments or innovation in that area during that time? And I know that's kind of putting you on the spot a little bit, but are there, Clayton, are there any digital kind of platforms or solutions or ideas, even if they're kind of at a very early stage, things that are in the twinkle of developers' eyes, that you see as being quite interesting and promising, perhaps particularly with a view of equity in health?
Thanks, Nis, and thanks to the contributor for the question, because I think it's a question that's often asked and extremely pertinent, and the answer is yes. There's been some not only useful technology acceleration, but we've seen some really amazing innovation happen just in the last 6 months. Some are saying that we've come as far in 6 months as we would have in a decade in terms of implementation, and I don't think that's too far from the truth. What we've seen is essentially two things. We've seen technologies that have been around for quite some time, like telemedicine or teleconsultations, being literally thrown right into mainstream primary healthcare. And that's had a profound effect both upon, so to speak, forcing primary healthcare individuals, and I've used consciously the word force, to kind of take these technologies where maybe there was a little bit of latent resistance previously. And it's also really, I think, opened up the opportunities or the awareness of the individual as to what types of technologies can actually be fairly easily utilized, and quite often from the palm of their hand, using a mobile phone as a conduit. So so that's kind of the first. The second is really amazing technological acceleration that I think will change the way that, for example, a doctor like Anna would actually work in the future. So some of these, for example, particularly in a COVID perspective, are low-cost solutions for monitoring remotely vital signs of an individual. And again, we're using a smartphone camera with a remarkably high level of accuracy that can detect things like heart rate variability, oxygen saturation, and so on. So it's actually giving, in real time, a capability for a clinician to actually have a very strong overview of both data, but also seeing the individual in terms of providing remote care. And I find it, what pleases me about these is that the cost of such solutions, or many of them, isn't exorbitantly high. So there is very low barriers to entry. And it seems that the tools themselves have developed to such an extent now that they're relatively intuitive for clinicians to pick up and run with. Now, that's not to say there are a number of social and ethical issues that can emerge around this, and including also integration of such tools and the data they produce with other longitudinal records that might exist in the health system. So it's not a perfect world yet, but I think in terms of COVID and inequities, then it's actually had the benefit of accelerating the digital tools, and also in many ways, maybe even as a secondary positive effect, actually reducing some of the inequities in access via digital tools.
Mm-hmm. All right, so I'm going to
Niels,
yes, go
sorry,
ahead, Emma.
could I
no,
could I add a brief comment to that?
Yes, yes, please.
And of course, to preface it by saying I have raised a lot of critical questions, but equally I see a great deal of exciting and innovative things happening. And one thing I wanted to highlight was during COVID, what we've seen is technology, so not just designed for the individual user, but more activist health responses in which those voices of particularly vulnerable groups who might not be heard have come together through technologies, through digital innovations, to sort of mobilize action where perhaps governments or healthcare systems have been able to meet expectations or fallen short. So just an example of that is in the UK, the Mutual Aid UK provided a sort of up-to-date interactive map of thousands of local groups around the world who were providing really important support to communities during the pandemic. And I think that's a really nice example of the potential of technologies to bring different user groups together across cultural context, albeit in this case during times of crisis, but to speak back to governments, to speak back to healthcare systems. So I think in the context of equity, it's also important to think about technologies in terms of mobilizing action, change, and voicing what those inequalities and health needs are. And I agree with Clayton. I think over the last few months, we've seen lots of really exciting examples of innovation, but they're also happening from the community level upwards. And I think it's really important that policymakers and organizations begin to gather some intelligence around that and see what's worked and what hasn't. And some of those are really innovative and exciting.
Thank you. Thanks very much, Emma. We're beginning to reach the end of our allocated 1 hour. So I want to kind of ask a question that's kind of been floated a couple of times on Slido in different versions of it. And that's the question, where next? I mean, there are many other things. I should just say there are many other things to explore. And I'm saddened by the fact that we have a limited amount of time, because it'd be lovely to spend the next hour or an additional hour talking about these things. But this question is one that's come up a couple of times, and that's kind of where next. So maybe I could ask each of you just very briefly in a kind of minute or so to kind of give your sense of whether it's on the kind of practitioner level for you individually, Anna, or for your colleagues, whether it's on the kind of research angle for you, Emma, or on the policy level for you, Clayton. What are the kind of the Gordian knots, the tricky questions that still need to be addressed? And maybe I can start with you, Anna, in this case, to kick us off.
I mentioned already, we don't know enough about how the lack of physical contact in the clinical setting, how it impacts outcome. So we have to look into that, because when we have a more nuanced view on that, we will be more able to discuss pros and cons, actually, when to use digital tools and when maybe not to. So that is one thing. Another thing I haven't thought through yet, but I was inspired. Language was mentioned. The language, the digital language, I know that is not the language, but language is key to make sense and to interpret. And language and digital tools, that's another field I think we should look into. Now you are 3 native English speakers, or 2? Niels,
I'm German.
You're German, yeah, okay. So we are 2 and 2. I mean, and we know it, when we communicate in English, we know that the others have an upper hand. Whatever, I mean, how much we put in to prepare ourselves. And if we translate this to the digital era or environment, we have the similar things. So who owns the language? And this must be part of digital literacy among doctors and health professionals and patients. So, yeah.
Very useful. Thanks very much, Anna. Emma, in a couple of sentences, over to you. Where next?
Yeah, just briefly, for me, I think transdisciplinary work and really bringing together multiple stakeholders to have these types of conversations. Designers need to have a better understanding of patient needs. Policymakers need further engagement with what communities are telling us. So I think bringing those people together in that space seems to me the crucial next step in some of these conversations. And I think short term, there's some really interesting questions. And I think Anna alluded to this about what we've learned through this sort of pandemic time. And if we reach this sort of post-COVID position, what has been the impact? How has that shaped expectations? And what do we return to? How do we get to a point where we take on board all these innovations that Clayton has described, but not place increased burdens on either patients or practitioners?
Thank you. Clayton, last word to you. Where next for WHO?
Oh, that's a big question. No, I'm going to actually hedge my bets back on the issue of data. I think we're going to see a lot more policy-based interventions that are going to begin to look at data both in its terms of its primary use and secondary use. And I think we're going to really start to understand what it means to leverage data both from an individual, a community, and also a kind of a health systems perspective. So I think a lot has come out of COVID that's been driving this, and I think that we're really going to see an acceleration of tools that both use data, but an open dialogue about what that means from the different perspectives.
Very good. Thank you very much to all of you. That's kind of the end of the webinar. We've come to the end of our allotted time. In fact, we're slightly over. I hope that's okay. Before we go, I wanted to remind those of you who are online that this is part of a whole series of webinars. You can find the link in the Slido chat box. Do please check out the other webinars as well. The next one will be on childbirth in the WHO European region, the different kind of experiences of childbirth across the 53 member states of WHO Europe. And that's going to be taking place on the 8th of October at the usual time of 12 o'clock GMT and 1 o'clock Central European time. So very much hope that you'll join us for that as well, or mention it to your friends and colleagues to join. As I mentioned at the beginning of the webinar, we have an evaluation form, which is also in the Slido box. You'll have to click on the polls section. Please do take a moment to fill that out. It helps us enormously to improve these webinars and also to get a sense of who's been listening in. Do leave your email address if you want. That's completely anonymous. Don't worry at all about that. But it'd be great for us to be able to stay in touch. And one thing that we will try to do, and maybe that's an incentive for you to leave your email address, is any of the questions that we didn't manage to answer on Slido, we'll be trying to answer them offline. We'll post them on our page, but we can also send them to you directly if you leave your email in the Slido poll. So with that, I just wanted to say thanks again to our panel members, to Emma, to Anna, to Clayton. Thank you so much for your time, for your insight. It's been a real pleasure listening to you certainly from my perspective. And I wish you all to stay healthy and well, and hopefully see you in person one of these days. That would be a great privilege. Take care.
Thanks very much.